Thank you very much. It's a great pleasure to be with you here today and to be able to share with you some of our experiences from England with the maternal immunisation programme against pertussis. And I'd like to thank the organisers for inviting me here today. So, we've already heard about pertussis as a disease caused by Bordetella pertussis, a gram-negative bacilli. It's an exclusively human pathogen transmitted through close direct contact, and you can infect others up to around 21 days after symptom onset. It's important to be aware that neither infection nor vaccination will confer lifelong protection. However, what we do tend to see is that people who have a history of immunisation or disease then go on to have less severe symptoms if they do develop pertussis. Again, we've already seen the severe complications and the fact that these are usually in very young infants, and the reason for that is because these young infants are not yet protected through the immunisation programme. So I think it's important to kind of think about what pertussis actually looks like. So this is a young child with conjunctival hemorrhage due to the severity of the coughing. It really can be a very, very severe cough, even in older children and adults, so it can lead to rib fracture and so on. And I'm hoping this will play, but I don't quite know how to do it with one of these without a... I'm not sure it is going to do it. We should see a child coughing, but no. Sorry, that was, you can, if you go online, oh, someone else is going to try, no. You can see them, but you can't hear them. I think it still gives you a sense of how severe that coughing episode is. And the parent does come in to intervene in a moment. Thank you. Okay, I just wanted to share that so that we could get some sense of that severity of the cough, because I think a cough illness, it's quite difficult sometimes if you haven't seen that yourself to get a sense of how serious it can be. So I'm also going to take a little step backwards and look at a historical perspective here. So this is going back to 1940, when we had very big epidemics of pertussis. 1957, we introduced the wholesale pertussis vaccine. We can see an immediate decline in pertussis disease. As has already been explained, there was a vaccine scare situation in the mid-70s, early 80s, that led to a fall in coverage to about 30%. So it was a massive reduction. And as a consequence, you can see these disease outbreaks that occurred. So this was, in a sense, this was a natural experiment that showed how effective the vaccine actually was. In 1990, we introduced an accelerated infant programme, so babies were immunised at 2, 3 and 4 months of age rather than 3, 5, 11 months of age. And the idea was that that would help increase coverage, because you tend to have more visits to general practice when babies are very young. In 2001, we introduced a booster dose, an acellular booster dose at preschool. Then in 2004, we moved to an acellular programme throughout infancy as well. So we now have 3 doses in infancy at 8, 12 and 16 weeks of age, with a booster dose 3 years after completion of that primary course. And just to highlight that this is the period I'm going to be focusing on after this slide. So you can see it kind of kills it a bit, that arrow, but the arrow comes in to show you where our outbreak actually occurred. Okay, so that's our schedule. So this slide is that focused in incidence of disease, and we can see that very marked peak in 2012, where we had more than 10 times as many cases reported, and these are all laboratory confirmed cases, as we had done in the previous peak year. So we still see peak years every 3 to 4 years, and this was our last peak. It's barely noticeable on this graph. And if we look, so that's when we declared our outbreak in April 2012, so it's a bit earlier than here. And if we look at this by age, what we have here are the bars representing total cases of laboratory-confirmed disease, and the line shows the incidence rate. So here, this shows you very clearly that whilst the burden of disease in terms of numbers is in that age group 15 years and older, actually, in terms of incidence, the highest burden is very much in these very young infants. And when we look even more closely at those infant cases, or when we looked at those that were arising between 2011 and August 2012, what this graph shows is the onset of disease by weeks of age. And what this very clearly showed us was that the vast majority of cases, and I think it was about 75% of all of our infant cases, actually occurred before those infants could be protected by even their first dose of vaccine. And in fact, all of our infant deaths, and we had 14 in 2012, occurred in infants who were under 9 weeks of age. So this was a gap in terms of the protection offered by our vaccine programme. And so Lucy's already explained the rationale, and this was identified as being the only really potential way to protect babies from birth, was by offering women vaccine in their pregnancy. So this would boost immunity in the pregnant woman, optimise that transplacental transfer of maternal antibody, and also offer passive protection, so protection from the mother being protected in that infant in their first 2 months of life, as well as the direct passive protection offered through those maternal antibodies that were then circulating in the infant. And we know from other research that mothers are a really important source of infection in these young babies. So when the programme came in, it was introduced in October 2012, and at that time we were offering a single dose of Repavax IPV vaccine, so we also have IPV in the vaccine we use. That's just a pragmatic decision because that's what we use in other parts of the programme. And it was to be ideally given between 28 and 32 weeks gestation and offer in every pregnancy. We'd seen a couple of changes, so we changed to Boostrix IPV from July 2014. This is a very similar vaccine, it just has 2 fewer of the Pertussis components. So we have 5 Pertussis components in the Repavax and 3 in the Boostrix. And then from April 2016, the guidance was changed to advise that women could be vaccinated from 16 weeks and ideally between 20 to 30 weeks gestation. Usually it was recommended after the 20-week scan, and that was just to avoid any erroneous link between anything that showed up in that congenital anomaly scan and the administration of the vaccine. And in fact, it was very well received by the press, and we know we have had quite a lot of adverse media attention in the past, but this was very well received. The press had also covered a number of those baby deaths. So I think there was a recognition of the importance of this programme. So I'm going to go on to share with you some of our evaluation of vaccination in pregnancy. And I think it's one of the important issues for us very early on was that we didn't really know how acceptable it would be to women to be taking up the offer of vaccine in pregnancy. And we did a piece of research quite early on where we asked women who had recently given birth or were pregnant. I think they all had children who were under 2 years of age. Would you accept a nationally approved vaccine offered by your midwife or GP surgery if it would help protect you against a disease that is potentially life-threatening? So that's this column here. 94% said they definitely or probably would take up that vaccine. And then the same question, if it would protect their baby against a potentially life-threatening disease. And again, 96% said they definitely or probably would take up that vaccine. So actually very high levels of acceptance. This is a theoretical question at that time, but women were quite accepting of this idea. And again, this is something that we keep coming back to, but we also asked where these women would ideally like to get information from if they were being offered a vaccine in pregnancy. And you can see that a very high proportion identified their midwife, and a very high proportion identified their general practice or own doctor. And I think that actually captures some of the nurses as well that are working in those general practices. So healthcare professionals are a really important source of information. And of 70%, we have ongoing surveys where we ask a number of questions, and 70% of parents of young children indicated they'd had a discussion with a health professional before going ahead to vaccinate their babies at that stage. And of those, half felt much more confident after having that discussion, even those who were already going to vaccinate anyway. So it's really, really important, that interaction between health professionals and not only pregnant women, but other parents. So how are we doing? Well, this is our coverage data, and those bars are the proportion of general practices that are reporting at any particular time. So mostly that's very high proportions of our general practices that are providing this information. And we can see that in recent years, our level of uptake has been around 70%, which we think is a fantastic achievement, although of course we would really want to immunise that other 30% as well, but this is a huge achievement. And when we look at the changes since, I've mentioned we moved to an earlier recommendation, and this is just to highlight that we are now vaccinating at an earlier stage in pregnancy. So essentially those blue and yellow bars are indicating early delivery of vaccination. And this is important because we know that prem babies are disproportionately represented in our hospital admissions for pertussis. So this all helps go towards protect those early deliveries as well. These are, you've already seen a version of this graph, but these are our pertussis laboratory confirmations, and this first graph shows those in all age groups from 1 year and above. And what this shows is this 2012, this 2012 peak, and also since that 2012 peak, although levels of disease have fallen slightly, they have never gone back to the pre-2012 period. So we still have an outbreak situation, and we are still seeing elevated levels of disease in these older age groups. And that's really important because, of course, that's a source of infection for those very young babies. When we look at the younger age groups, and I've highlighted the y-axis just to indicate what we are looking on a different scale here. Again, we see that 2012 peak, but in these, and in particular this under 3-month group, who of course is the group targeted by this programme, we see a fall in levels following the 2012 peak, back down to actually below the levels that we saw before 2012. And in 2018, we had the lowest number of cases that we ever had reported and the lowest incidence rate. So this epidemiology is consistent with a direct impact from that maternal vaccination programme. And these are our deaths. So again, here we can see those 14 deaths in 2012. Since that time, we've had a further 19 deaths in infants. And actually, of those 19 deaths, only 2 of those babies had mothers who had been vaccinated. And of those 2 mothers who were vaccinated, they were both vaccinated very close to delivery, so we would not have expected those babies to be optimally protected. This programme has a huge level of protection against death in these young infants, and I'll show you that in a more scientific way in a moment. When we look at the effectiveness of the programme, there have been a lot of studies of this done now. We've kind of got 4 studies here that are based on the data in England. So these were the first 2 studies that were published. And really to highlight this end column, which gives you the vaccine effectiveness of around 90%. And subsequent studies, as I say, 2 of those are ours. One is with data up to 5 years post the introduction of the programme. And another one of these studies is from Spain. And there's also another study from the US that, again, shows very similar levels, around 90% vaccine effectiveness, a very highly effective programme. And if we look at the risk of serious outcomes, there's some data from the States that suggested infants born to vaccinated mothers had a lower risk of hospitalisation, of intensive care admission, and shorter hospital stays, with an adjusted vaccine effectiveness for the prevention of hospitalisation at nearly 60%. When we look at our data, and this is for 5 years' worth of the programme, the vaccine effectiveness against hospitalisation was 89%, and this is based on laboratory-confirmed cases, whereas this top study was based on categorisations, coding on admission for pertussis. And our effectiveness against death was 97%. So huge, huge impact. And of course, we've changed to earlier vaccine administration, and one of the concerns was, would we then compromise the effectiveness if we were giving this vaccine a little bit earlier? And this graph just summarises, we can't do it by gestational age because that's not the way the data are collected, but this is by the number of days before women give birth, and what this really highlights is that we have no significant difference in effectiveness depending on the time before delivery, with the exception of this last column over here, which is women who will immunise a week before delivery or after they had delivered. So here, the only protection you would expect would be that cocooning type effect, which is when, by protecting the mother and stopping her being infected, you're then reducing the chance of the infant being infected as well. Another kind of area of concern was that by having these circulating maternal antibodies in these young infants, when they are then vaccinated themselves, that might interfere with their response to their own vaccinations. And there were there have been a number of studies, immunogenicity studies, so laboratory-based studies, that have suggested that there is a reduced response in these infants. However, we don't have a true correlate of protection, so we don't really know what level of antibody is indicative of a protection in an infant. And since we've introduced these programmes, we've been able to go on to look at this in terms of prevention of clinical disease rather than a laboratory measure of immunity. And from studies in the US and in England, we have to date found no evidence that babies born to vaccinated mothers are more at risk of disease after their infant vaccinations than babies born to unvaccinated women. And a number of those immunogenicity studies have also looked at what happens after boosting, and those have also tended to suggest that any effect has disappeared by then as well. But we can't find any evidence that when you're looking at pertussis disease, there is a difference between those babies born to vaccinated and unvaccinated women. In terms of safety, now this is just based on a review that we did that was published in 2018, so there have been more studies published since then, and this at that time covered 150,000 vaccinated pregnancies, but millions of unvaccinated women as well as the comparison groups. And these studies overall found that there was reassuring evidence of a similar risk of maternal, fetal and infant outcomes, such as preeclampsia, preterm delivery, stillbirth or congenital anomalies in vaccinated and unvaccinated pregnancies. The only condition that has been highlighted is chorioamnionitis, which is inflammation or infection of the chorion and amnion membranes or the placenta. However, although this has been identified in maternal chorioamnionitis, there are certain associated conditions in the infant. So these have also been looked for, and it has never been found or no increased risk has been found for these other conditions listed that would be indicative of an impact on the infant. And there have been, I think, 6 studies that have looked at this. 3 have found a small but significant increased risk, and the other 3 studies didn't find a significant increased risk. So the vast number of studies have been really reassuring about the safety of this programme. We have moved from a different model of delivery where initially when the programme came in we were delivering virtually all immunisations through general practice, whereas now we are increasingly moving to a midwifery-led delivery of vaccine. So more and more midwives are immunising pregnant women, and there is evidence that this is helping to improve uptake, although there are still issues around the transfer of information kind of from the midwifery services to general practice, and then when that information has reached general practice, for that to actually be recorded in a way that the information can be extracted easily and show true vaccine uptake in those practices. So, in conclusion, despite the success of childhood immunisation programmes, pertussis remains a global public health concern, and additional strategies have been required to optimise control and protect infants who are at that highest risk of severe disease. Immunising pregnant women has been shown to be a safe and highly effective strategy in protecting young infants in the first months of life in high-income settings. And what I should have said as well is that because we're going to have to show cost-effectiveness for this programme in order for it to be made a permanent programme, and our Joint Committee on Vaccination and Immunisation will be looking at this in June. So our cost-effectiveness analyses at the moment have indicated that in the years from the time this programme was introduced up to the end of 2017, it has prevented between 85 to 180 infant deaths and between 1,500 and 4,400 infant hospitalisations. So that is the kind of the level of difference that this programme is making. And the challenge remains in achieving kind of even better uptake in these pregnant women in order to offer that optimal protection in these very young, vulnerable infants. Okay. And I'd just like to thank everyone who's involved in providing this information and other people in the team that I work in. Thank you very much.